Hi, everyone. Thank you all so much for joining us today for number 10 in our 2024 LBDA webinar series, Empowerment Through Education. I am Shannon Chiu, a Senior Associate Consultant and Assistant Professor of Neurology at Mayo Clinic, Arizona. I'm a movement disorder specialist and completed my fellowship at the University of Florida. My current research is in the application of diffusion-weighted MRI and electroencephalography in dementia with Lewy bodies and development of these techniques as potential biomarkers. Many thanks to the LBDA for inviting me today. It's really a great honor, and I'm excited to be talking to you about autonomic symptoms in Lewy body dementia. I was really thrilled to see how many of you pre-registered for this webinar, so thank you all so much for your time. I hope my talk today will be informative, or at the very least, help reinforce some concepts and tips you may have heard from LBD doctors that you've seen. So without further ado, I'll get started on our topic today on autonomic symptoms in LBD. So here are my disclosures. So learning objectives today, we will first kind of go through and review common autonomic symptoms that we can see in Lewy body dementia. And then for each symptom, I'm going to highlight first what I consider lifestyle modifications, essentially non-prescription management for each symptom. And then for some of those where we do have potential prescription medication options, I'll review that after. So to take a step back, what is the autonomic nervous system? So the autonomic nervous system is in control of regulating a variety of different body processes that occur without any conscious effort, so just happening in the background. It's responsible for example, regulating involuntary body function like your heart rate, your blood pressure, blood flow, breathing, urination, digestion, and much more. We normally think of the autonomic nervous system as having two divisions, what we call the sympathetic nervous system and then the parasympathetic nervous system. With the sympathetic nervous system, we kind of think of, the fight or flight response. So when we were, back in the day, hunter-gatherers, this will be where your body just kicks into automatic functions to let you either be able to run away from the predator or fight them off. So for example, your body is naturally going to have your pupils dilate so you can see better. It's going to expand your lungs so you can breathe better. It's going to pump more blood to the heart, etc. And then on the flip side, with parasympathetic nervous system, this is your rest and digest system. So almost doing a lot of the opposite functions that the sympathetic system does. So instead of dilating, your pupils will get more constricted, and then more blood flow, for example, might go to the digestive system where you can digest and kind of restore your energy. So in Lewy body disease, the parasympathetic, the sympathetic components, and if we think about kind of the central and peripheral nervous system, because really they're pathways that go from the brain, spinal cord, all the way down to the periphery. So in Lewy body disease, all of these different components can be out of sync, and that's why we can see the symptoms that we do when we talk about autonomic dysfunction. So this can include gastrointestinal malfunction, cardiovascular dysregulation, sweating changes, sexual dysfunction, urinary disturbances, and more. So we'll talk more about each of these symptoms shortly. Know that autonomic dysfunction is very common in LBD. So when we think about prevalence of this in just Parkinson's disease, for example, it's anywhere from 50 to 70% or more. And likewise in dementia with Lewy bodies, also very common that, at least 60%, if not more, patients experience autonomic dysfunction. Keep in mind, also that autonomic symptoms can really occur at any disease stage. So it's not necessarily just when your disease is a little bit more advanced. So we can actually see changes even early in what we call the prodromal stage. So that's the time even before you might have, clear cognitive or movement problems that lead to your neurologist, being able to diagnose you with LBD. So a classic example is something like constipation, which we recognize now can actually present, years in advance before patients actually get a clinical recognition or diagnosis of LBD. And then, as I alluded to earlier, again, keep in mind that the autonomic system symptoms that we can see really come from disruption along, the different pathways involving both the central and the peripheral nervous system, all mediating autonomic functions in your body. So for those who like to kind of peek under the hood of the car to kind of figure out more details, why exactly something is happening, what we call in a way sort of what is the pathophysiology of autonomic dysfunction. Well, it links back to, as you may know, for Lewy body disease, that the hallmark feature is related to abnormal aggregation of this protein called alpha-synuclein. So it turns out when we look at patients who undergo autopsy and we look to see, where do we find these abnormal accumulations of that protein, synuclein, we find them in areas from the brain out through the spinal cord, all the way out to the periphery, in regions and pathways that have to do with autonomic function. So in the brain, we see the abnormal deposits in regions that have to do with, breathing control, sweating, some of what we call, even the what your heart is doing, and then all the way out. So even to the heart, to the blood vessels, bladder, the gut, we find abnormal aggregations of these protein along these various pathways. So it kind of makes sense that we see such rampant or kind of high prevalence of autonomic dysfunction in Lewy body disease or Lewy body dementia. So here's a roadmap of all the, or at least I would say most common autonomic symptoms that we can see in LBD and that we'll focus on for the talk today. So I think one of the most common things we see in LBD includes something called orthostatic hypotension, which is just in a way a fancy term to describe what happens when patients change position and their blood pressure drops. So when they go from lying, sitting to standing, they get symptomatic dizziness or lightheadedness, which we'll talk more about. And this turns out to be related to low blood pressure that can occur as a result of that position change. Other things that we can see, for example, with the GI system going awry. So commonly, this may manifest as constipation, and then something, medical term, we call it gastroparesis, but it's really just to describe when patients have delayed or slowed gastric emptying. So things are not moving through the digestive tract as quickly or as efficiently as it should be. You can commonly see urinary issues. So some symptoms include, for example, urinary frequency, urgency, and incontinence. We'll talk about a few other things that you can see as well. And then I lumped together some secretion-related issues, again, that fall under autonomic symptoms. And these relate to, for example, you have too much saliva leading to drooling, runny nose, dry eyes, which may result from just abnormalities with tear duct glands, for example. We can see sweating changes and even sexual dysfunction as well. So to start with, we'll talk about first orthostatic hypotension. So again, symptoms of this relate to when you have that position change going from lying to sitting to standing, where you're going to have inadequate blood flow going to the brain, and that's what's going to cause you to have these variety of symptoms, which I've included here. So often patients will just describe to me they feel dizzy when they have to stand up. And then as a neurologist, I have to dig a little bit further because what do you mean by dizziness? And classically with orthostatic hypotension, it's that sensation where you feel lightheaded, feel faint, like you might pass out. So that's why I listed here sort of the second common symptom is actually here, patients having had history of either near fainting spells or actual episodes where they blacked out. So the fancy medical terms we use for these are pre-syncope if it's a near fainting episode, or if they actually stood up and then lost consciousness and blacked out. You might hear your doctor refer to this as syncope. Now, as a result of this, perhaps not surprisingly, you might imagine sometimes patients might have falls. So again, as a neurologist, when I'm just taking the history and patients just describe to me, that they've had history of falls, I really always want to find out, what are the circumstances that led to these falls. Obviously, if someone, had a fall that's related to a freezing episode or they're wearing off from their dopamine medications, management of that is very different versus if they fell because they stood up, got a little lightheaded, and likely because of that blood pressure drop that we're talking about here, that's why they fell. Again, treatment would be very different if that were the case. Other symptoms that we can see, and some of these may seem a little bit non-specific, which is why it takes us a little bit of detective work to kind of figure out the underlying cause. But most of these, again, as a result of that low blood pressure that can come from your standing up, patients might tell me they have blurry vision, they feel fatigue, they just feel really weak in general, foggy headed. And there's actually even a particular type of pain that we almost consider pathognomonic or pretty characteristic of what we think of with orthostatic hypotension. And what they describe is, when I ask them where the pain is, they'll describe in the back of the neck, down both shoulders. And if you have to draw out that distribution, it kind of looks like a coat hanger. So we actually call this coat hanger pain. And when I hear that, I do think most likely, due to something like orthostatic hypotension, again, where you stand up and with that position change, it leads to a drop in blood pressure, kind of blood draining from your head. And then sometimes, again, with that position change, sometimes people may describe a sense of shortness of breath. So it's another symptom that we may hear in association with orthostatic hypotension. So how do we diagnose this? So we do need to, objectively, to help kind of confirm what patients tell by history, look at what your blood pressure and heart rate do when you are in various positions. So ideally, we take one first when you're just at rest, lying down, take your blood pressure, heart rate, and then we have the patient sit up. And then after a couple of minutes, we'll remeasure blood pressure and heart rate. And then finally, from there, we'll have you then stand up, again, wait a couple of minutes, and then remeasure your blood pressure and heart rate. We're essentially watching to see, what is the trend? What is your blood pressure and heart rate? What do they do as you change position from lying to sitting to standing? By strict criteria in order to diagnose orthostatic hypotension, we are looking to see that it drops by a particular amount. So there's like a threshold in terms of that blood pressure. So classically, when you have someone, let's say their blood pressure is 120/80, we're looking at that top number, for example. Did it drop by, at least 20 millimeter per mercury when you changed position? Or with that low number, so that 120/80, that denominator, did it drop by more than 10, when you went from sitting to standing, for example? So if it crosses one of those thresholds, then, we would say this is consistent with orthostatic hypotension. Now, more formally, there's also something called a tilt table test. Cardiology often does this, and then it's also usually part of what we call an autonomic reflex screen, which is a battery of tests that your doctor can order to look to see, do you have autonomic dysfunction? So that battery includes, they not only look at your heart, but they also look at your breathing pattern, sweating pattern, etc. But as part of that, so with the tilt table test, it's a way for them to very accurately measure, when you're lying completely flat, 0 degrees, what your blood pressure, heart rate is, and then they continuously monitor as they slowly increase the tilt of that table, 10, 20, 30, 40, 50, 60, etc., until you're upright. And they measure, what exactly is the trend of your blood pressure and heart rate. So obviously that's another very careful way to measure and diagnose orthostatic hypotension. But at home, it is, again, something easy that you can do and help, give your neurologist more data on. So oftentimes when patients, message me and tell me about symptoms that alert me to the possibility of orthostatic hypotension, I right away tell them to try to keep a blood pressure log at home so they can give me some data to review. And then the way you can track that at home is, first take either a lying or a sitting kind of resting blood pressure heart rate to start with. Then stand up, but wait, at least a couple of minutes, ideally up to 3 minutes before you re-measure it. And the reason is that, most of us, if you measure the blood pressure and heart rate right away with position change, most of us, just physiologic, it's going to have a little bit of fluctuation. But with something like orthostatic hypotension, we're going to see an abnormally sustained low blood pressure, even after you wait a couple of minutes. So it's not going to bounce back up. Your brain just doesn't send that signal to the heart to kind of compensate. So that's what we're looking for. And usually I have my patients measure it, a couple of times within one day, because what your blood pressure and heart rate, what they do in the first thing in the morning versus midday versus late in the day might be a little bit different. So it's helpful to kind of see if there's a trend in what your blood pressure does depending on the time of day. So in terms of treatment approach, so first thing first, and I always, and you'll actually see this as a common theme for other symptoms I'll review shortly in terms of autonomic dysfunction. I first have the patient just go back and we review your medication list first and foremost, because is there anything that you're on that could be making your symptoms worse? So commonly, a lot of my patients do have history of high blood pressure, so you may already be on actually medications that lower your blood pressure, or maybe you have a little bit of heart failure or issues with swelling, so you might be on water pills. So all of these, could contribute to obviously lowering your blood pressure further. So, if that's the case, I usually encourage patients to talk to your primary care doctor to re-review, and, maybe you don't need as high of a dose anymore if your blood pressures are no longer running as high as they used to be. Or maybe we can change it more to as needed, for example, with some of the water pills, and not be scheduled daily. And then how about, how does your blood pressure change in relation to dosing of your dopamine medications that you take for your movement problems, your Parkinsonian problems? Because sometimes we do know there can be side effects. So after you take your carbidopa, levodopa, or Cinemet, for example, within 30 to 60 minutes, do you feel extra tired? Is it because your blood pressure is dropping as a result of that dose? And if that's the case, then, that's a good reason to review this with your neurologist to see if there's anything to adjust. And then for some of our male individuals with LBD, for example, common issue with enlarged prostate. So again, they might be put on something, as an example, tamsulosin, which also very well known to drop blood pressure as a side effect. So we're on the lookout for that. And then if you have sexual dysfunction and we're put on, as needed Cialis or Viagra, for example, that's another class of medication we're on the lookout for, because again, a common side effect of this type of medication is that it can lower your blood pressure. So these are things that, again, we kind of review to see, can your local doctor help us out a little bit, either finding an alternative, or is there anything we can do with how you're currently taking it? And then there are also some antidepressants that may have a little bit higher risk in terms of worsening, again, the low blood pressure issue, orthostatic hypotension. So again, another reason just to review your medication list. And then I often encourage patients to keep a diary. So not just in terms of, tracking like a blood pressure log, but also try to find out, is there a trend? Do symptoms occur at particular time of day or depending on activity that could give us additional clues? So for example, do your blood pressures drop usually, with meal times or after a meal? What about if you drink a little bit more alcohol? Or is your blood pressure usually worst first thing in the morning? Or perhaps with bowel movements, or if you have to strain a bit, any relation to if you take a hot bath or a shower. And then what about, if you're a little bit more active or with exertion, again, is that a trigger for lowering blood pressures? Obviously, finding out what your particular pattern is, again, can help your neurologist and team of doctors to just give you additional tips that would be more personalized for you. And then, of course, don't forget there can be other things that can worsen or cause, the issues you're having with the low blood pressures. So, for example, if you're sick, dehydrated, maybe you were just battling some gastroenteritis, that can, of course, be a reason to at least worsen your low blood pressure issues. Or if you're sick and you have a fever, or you have anemia for any reason, you might be losing blood from some cause that needs to be investigated. Again, these are some other sort of medical or systemic causes that can just contribute to the problem you're having with the low blood pressure. So just keep that in mind. And then next, in terms of the treatment approach, so some of these might seem straightforward, but I always want to, again, emphasize non-prescription medication, kind of lifestyle changes that you can try to adopt. So obviously, you might want to avoid sitting for a long time, or likewise, if you stand for a long time, because that can trigger low blood pressures. And then when you stand up, make sure you do so slowly. And then sometimes crossing your legs before standing up, again, these are just signals to your brain to pump blood more to the brain so that doesn't pull in your feet, when you stand up. Or you can try doing a few ankle pumps. And then we also often advise our patients to raise the head of the bed, in part, for example, to lower the symptom you might get at night where you have increased urinary frequency. Again, it has to do with gravity and how things are just pulling more depending on, if you're lying more flat at night and more gravity kind of pulling your kidneys to pee out. So if you raise the head of the bed, again, some of that can help symptomatically. And then in terms of other sort of diet modifications to consider, salt and fluid are some of the mainstays. Now, I did put if able because it's very important to make sure that you review these strategies with your local doc, so whether it be your primary care, your heart doctor, kidney doctors, because they may not feel comfortable for you to just liberally increase your salt and fluid if, let's say, your heart or your kidneys, for example, are not as healthy as they used to be. So they might not be able to handle and filter out, the extra fluid or salt. So might have to discuss with them and hopefully can come up with a compromise so that you're not on strict, complete no salt, no fluid diet, because we do know that doesn't help when you're battling the low blood pressures. So if you're able to increase salt and fluid, so with fluid in a healthy adult, we say try to take in 2 quarts of fluids per day, or that's about 8 ounces of glasses of fluids per day. And then another tip that may be helpful if first thing in the morning you're more prone to low blood pressures is consider having a glass of cold water by your bedside. And you can almost do like a little bolus first thing in the morning before you get going to help, again, that blood pressure, help the blood pumping to your brain. Another thing to consider is watch out for carbohydrates. If you eat a big, heavy, say, pasta meal right afterward, not surprisingly, more blood's just going to naturally go to your digestive tract to try to, rest and digest that food. So if you're going to be up and about and be more active after a heavy meal, again, you may be at higher risk for that blood pressure dropping because right now your body's trying to focus on digesting that food. So just be aware if it's a heavy carb meal. And then, in moderation, or if you can try to reduce beverages that can, again, increase your risk for orthostatic hypotension. So caffeinated beverages, alcoholic beverages, common things we just say to try to reduce. And then consider eating smaller, more frequent meals. Again, if you are someone who is more prone to having that low blood pressure after meals. And then in terms of other strategies, a big one in terms of trying to adopt with lifestyle modification is introducing things like compression stockings, abdominal binders, again, very helpful, almost like assistive devices to help boost that blood pressure. And with compression stockings, the higher you can get it, the better. So certainly at the very least, if you can get it above the knee, but then the higher kind of up the thighs, the more effective it would be. And then don't forget, again, something perhaps obvious, but important for me to reinforce. If and when you feel warning signs, try to alert someone that you're feeling it. And if you're a safe place, try to see if you can sit or even lie down to prevent a fall or any injury to yourself if you were to become more symptomatic from the low blood pressures. So now the things that I just reviewed, were just not enough and you're still having pretty bothersome symptoms from the low blood pressures with precision change. We do have some prescription medications that your doctor can consider. So common ones include something called fludrocortisone, there's midodrine, droxidopa, and then I grayed out here pyridostigmine, even though it can help boost blood pressure. It's, I would say, usually not well tolerated by a lot of my patients because of various kind of stomach upset related symptoms. So usually I would say, even if it might have helped a little bit in terms of boosting blood pressure in the long run, a lot of my LBD patients aren't able to take this consistently. So these 3 prescription medications, though, sometimes used in combination, can be effective. Now, cautionary word about these medications: we always advise patients to avoid taking these within a couple of hours of lying down, whether it's to take a nap or if you're going to bed. Firstly, it kind of makes sense because we want these medications to be focused on your waking active hours. We want to help you when you're going to be trying to do your activities while upright. So it kind of makes sense that you don't need to take a dose so close to bedtime anyway, because we don't need to worry about boosting your blood pressure when you're lying down and not doing it as active things as you are during the day. The other reason why we kind of caution is that, again, going back to gravity, when you lie down, to take a nap or go to sleep, blood is naturally already, by way of gravity, going to go more towards your brain. So that's already going to increase your blood pressure a bit more going to your head. So if you take these medications on top and then are going to lie down shortly thereafter, then it's just going to make your blood pressure going to your head, at risk for even going sky high. So that's why we caution, not to take these if you're going to be lying down within a couple of hours. And then last thing, just to kind of emphasize, at the end of the day, with all of these different strategies, my goal, and I think, for neurologists treating your LBD, we're not treating the numbers itself. Our goal is to try to improve your symptoms and functionality. So I do have some patients where even after we adopt, some of these different approaches, they might still, if we track their blood pressure log, we still see a little bit of that drop when they stand up. But if they're telling me, they feel better, they don't feel like they're going to faint like before, and they can be more active in their day-to-day life, then that is what, that's a victory. That's what I'm shooting for. I'm not going to, increase your dosage just to try to treat the number itself. So I didn't want to bring that as an important point. So next, moving on to common gastro-autonomic symptoms. So common things we can see include constipation. I think most of you probably know what that means in terms of, either harder stools, less frequent bowel movements, having to strain when you go to the bathroom. And then another common thing we can see is, again, that term for gastroparesis, which is just to describe when things are moving a lot more slowly than they should through the digestive tract, so kind of slow GI motility. And as a result of that, you might experience symptoms like nausea, bloating, feeling full easily, decreased appetite, even weight loss. So how do we manage this? So from the constipation standpoint, so again, taking a step back, you want to make sure that, if you did suddenly experience, more of an acute change in your bowel habits, make sure this is not associated with other potential GI symptoms that might warrant different evaluation or treatment. So for example, you also develop new bleeding, from your from the rectum, or unintentional weight loss or anemia, then again, we just low threshold to have you see a GI specialist to make sure nothing else is going on. We don't necessarily just want to jump to blaming LBD for your constipation, just as an example. And then again, don't forget about, taking a look at your medication list to make sure, are you on anything that might be worsening the constipation, and can we do something about it? So commonly, for those with chronic pain problems, they might have been prescribed, narcotics. So that's famous for worsening constipation. Similarly, if you have iron deficiency anemia, you might be on iron supplements, and that, unfortunately, with the oral iron supplement, we also know that's commonly associated with worsening constipation as well. And then in terms of first steps, thinking about other lifestyle modifications in terms of treating constipation, it comes back to fluids as a big one. So trying to increase, to at least 8 glasses of 8-ounce volume fluids per day. Try to add more fiber to your diet. Maybe consider eating smaller, more frequent meals. Exercising regularly is very helpful because we do know, for example, exercising those abdominal muscles is actually going to help improve constipation as well, kind of moving things along. And then you might recognize this figure as something like a Mediterranean diet, which, while we don't formally prescribe this, for our LBD patients, I think the general principle of the Mediterranean diet is one that we like to promote. So for example, big emphasis on fruits, vegetables, healthy greens, the good oils, legumes, more fish and seafood, less red meats and sweets, making sure you hydrate well, exercise. So these are, general principles that we would recommend, even in cases with helping with constipation. And then I often have had patients ask, about the gut, in terms of bacteria, inflammation. And there's certainly a lot of research on this. And anecdotally, I have had many LBD patients tell me when they started, prebiotics, probiotics, or, they looked for special yogurts that seem to have more of some of these strains of bacteria. They did find constipation improving. So by all means, I think it's something that you can try for yourself as well. I think on the research side, this is a very hot topic. So I think definitely more to come in terms of how the gut plays a role, and symptomatically in terms of what else we can do to help with constipation on that front. Now, when diet and exercise are not enough, again, there may be over-the-counter or even prescription medications that we can recommend to try to help you further. So for example, stool softeners like Colace can be helpful if stools are really hard. And then there are different laxatives, and they work in various ways. Things like Miralax, for example, they help to pull water in the colon to ease constipation that way. And then we have what we call stimulant laxatives, so like bisacodyl or Dulcolax, Senna. These are other examples where they promote the muscle contractions in the digestive tract, and that's how they work to relieve constipation. Now, in more severe cases, and usually I'm eliciting GI their help at this point to also help guide and monitor response. There are a few prescription medications out there that can help. They are better studied in just, kind of classic Parkinson disease patients, but we have started to use this more in LBD as well. These include Amitiza and Linzess. So for gastroparesis, again, when things kind of back up and things are not moving along as quickly as they should, what else can you do about it? So again, trying smaller, more frequent meals for some can help. Make sure you stay very well hydrated. Here, you might want to avoid, high fat content foods, to avoid it just kind of sitting at the bottom of your stomach instead of moving along to the small intestine, etc. And then sometimes, again, if able, very light exercise or just a little bit of walking after meals can help, again, just to kind of stimulate the digestive tract along. But obviously be careful if you're prone to getting a little lightheaded with exercise, or after meals. And then just a word of caution, because this is something, I often see GI doc prescribing to help with slow GI motility. They might prescribe something like Reglan. And for our LBD patients, we just caution use of this because this class of medication can block dopamine. So it might worsen, your movement, mobility, kind of in a way, your other LBD symptoms. So just be cautious. If you get prescribed this, I would generally try to avoid that. And then for some, with delayed gastric emptying, sometimes giving levodopa in solution may be helpful. Now, with common urinary symptoms in LBD, this can manifest in a variety of ways. For some, it's worsening frequency, and especially at night. For some, it might be urgency. That's a little worse. So that's that sensation where as soon as there's a little bit of urine in your bladder, you just immediately feel that urge that you have to empty it, or else you might have an accident. For some, it might be incontinence, and there are actually different types of incontinence. So part of it is also figuring out, what is driving the urinary symptoms that you're having. So just as an example, so with incontinence, you can have something called stress incontinence. And actually for our women with LBD, even unrelated to LBD, very common that we can see this, for example, if you have history of childbirth, where your bladder muscles are just no longer as strong. So it doesn't take much, take much stress to cause you to have a little accident. So if you have, stress from coughing, sneezing, laughing, those are circumstances, for example, you might feel yourself losing control of urine. Urgent incontinence, sort of what I described earlier, where you have that urgency where it just doesn't take much to almost like overstimulate your bladder, and you just, as soon as you have that little bit of urine accumulate, you immediately feel that, sensation you have to go. So sometimes accidents happen because you just can't make it to the bathroom on time. And then overflow is just where you just can't hold the same volume you could previously when you were healthier, and you have urinary leakage that way. Other symptoms can stem from if you have overactive bladder, hesitancy, or weak stream. And again, for some of our men with LBD, this perhaps maybe something you already experienced with the history of enlarged prostate, and now it's just a little bit worse. And then you can also have an issue where you may retain urine abnormally, and that leads to retention. And to one extreme, sometimes patients may need to self-catheterize themselves a couple of times per day to relieve that urine. So these are different symptoms that we may see in LBD. And as you may wonder, as we get older, some of these symptoms may be things you already experienced, or as I mentioned, if you have history of enlarged prostate, again, some of these may be chronic issues. And then just in the setting of LBD, not uncommon that we can see these just worsen with LBD. So again, from a management standpoint, first thing, again, I don't try to reach for prescription medications. I try to see what lifestyle modifications or other changes that we can do before jumping to trying a medication. So something to consider includes regular kind of prompted voiding, almost like with an alarm clock. So every couple of hours, you just make yourself go to the bathroom to take away that stress. And then sometimes it is helpful to wear pads, for example, overnight, or if you are going to be going out, again, to try to avoid that stress of having to find or get to the bathroom. I very often refer my patients to pelvic floor rehab and therapy for bladder retraining, and this is usually done through occupational therapy. And these are just pictures of exercises, for example, that can be done to help strengthen that pelvic floor, the muscles associated there. And then I usually have low thresholds to refer to urology, especially if some symptoms are, significantly worse than what they used to be. Again, just low threshold to rule out, that there isn't something else going on. And sometimes, of course, even as simple as a urinary tract infection, make sure we run some basic labs. So sometimes I do appreciate urology kind of doing more formal evaluation, because obviously if we find this is kidney stone or something else, obviously treatment would be much different than, trying to do these strategies that I'm talking about here. And then don't forget, if your constipation is very severe, the digestive tract is sitting right near where the bladder and the urinary system organs are. So if your constipation is really bad, that can actually cause you to even retain urine, for example. So it may help, if you get your constipation better managed, perhaps some of your urinary symptoms may actually improve as well. Now, again, if those lifestyle kind of non-prescription medication approaches are insufficient, what else can we do? So again, don't forget to go back and take a look at your medication list to try to see, are you on anything that worsens your symptoms? And then also beware, sometimes we may be prescribing you something, so including your LBD doc, that may, have some side effects that could be affecting urinary issues too. So for example, as the neurologist, I might be the one prescribing the memory thinking pill, so with donepezil or rivastigmine. And unfortunately, sometimes that can have some urinary side effects associated with it, so bear that in mind. And then for some, they may actually have already, by the time they came to see me for evaluation of LBD, they may have already been put on a medication by their outside urologist for, let's say, overactive bladder. So it's a common medication, something called oxybutynin. Now, again, I put a cautionary warning here because some of these medications, so like oxybutynin, can worsen, again, other LBD symptoms, so related to memory, thinking, worsening confusion. So we are very careful to try to avoid, or at least to see, can we switch this to something that could be less prone to causing side effects. So this class of medication I put in quotes here, anticholinergic. So it's kind of doing the opposite of what we're trying to do when we prescribe donepezil and rivastigmine to help with memory thinking. So again, just highlighting that, don't forget to take a look at your medication list just to see, is there something that we can do to optimize your current symptoms. But then next step, so, is there something else we can actually prescribe or look into to actually treat your urinary symptoms safely in LBD? Now, for some, you may be a candidate for actually getting botulinum toxin injections to relax those bladder muscles to kind of help. This may be effective for some, but not others, depending on whether that is, the issue with your urinary symptoms. And then for those, let's say with bladder overactivity and you're on oxybutynin, we sometimes ask the urologist to see if switching to something like mirabegron, or Mybetriq is the other name, may be an option, since this medication is a little bit safer and less likely to cause worsening of memory, thinking, confusion. So we usually, again, try to see if urologists can help guide that. And then for some of my patients with Parkinson's disease, to help with nighttime frequency, I have tried something called desmopressin nasal spray to help reduce those nighttime symptoms, which have been effective for many. I think limitations include potential side effects, as I listed here, and then for some, cost is an issue with getting this prescription for the nasal spray. So I would say those are just potential barriers to keep in mind. Excessive drooling is another common symptom we can see in LBD. So here's another, think about the autonomic dysfunction, where you have an inability to manage the flow of saliva in and around the mouth. So in LBD, you're swallowing less often or not completely, so that leads to saliva pooling in the mouth. So if you're having problems with drooling, again, think first about non-prescription medications. Oftentimes, I'm also hearing patients may have some swallowing changes. So again, I am initially first referring patients to see speech language therapists for some additional guidance and just in terms of recommendations for management. Other things to consider, you can try, sucking on hard candy or chewing gum, preferably sugarless. Again, the idea here is that the candy and gum would activate the jaw and the autonomic kind of swallowing reflex to help clear the saliva and providing at least temporary relief from the extra drooling. Don't forget to stay hydrated. And then another tactic is to wear a sweatband on your wrists, and this can help you during the day. You can discreetly wipe your mouth as necessary, and it's a relatively inconspicuous accessory. Now, you do need to consider kind of, on the medication side or getting a prescription medication if this is not enough to help manage the symptoms. Sometimes your neurologist can prescribe something called atropine drops. Classically, it's prescribed as an eye drop, but we can actually prescribe it so that you do it under the tongue a couple of times per day to help reduce that drooling. I usually prefer this to prescribing oral medications or something called glycopyrrolate, for example, or even I've had patients get prescribed a scopolamine patch to try to dry them out and reduce the saliva. But those medications have a little bit of higher risk, of causing side effects. Again, going back to concern for worsening memory, thinking, confusion. So I do think the drops is a little bit safer. But another very effective and also, thinking about kind of just local treatment without it worrying that the medication is going to get to the rest of your body and cause side effects is botulinum toxin injections that you can inject right into your salivary glands. So I show a picture here of the different glands that produce or are involved in producing saliva. So this can be very effective, and this can be easily done by your movement disorder neurologist. So excessive sweating, and perhaps more accurate to say temperature dysregulation, because sometimes kind of almost like the converse of sweating where you might just feel chills. That's very common. So think of just in general dysfunction in almost like your thermostat in LBD. So again, some of these may seem simple, but always helpful to just kind of see everything and just reinforce if there's some of these that you haven't tried yet. So consider wearing loose-fitting natural fiber clothing. And if you're prone to getting night sweats at night, maybe use natural light cotton bedding. Antiperspirants might help some. And then consider, clip-on or ceiling fans when you're sleeping at night. And then try to avoid foods and situations that might trigger sweating. So for example, alcohol, spicy foods, hot rooms. Don't forget to stay hydrated. Obviously, you're losing more fluids with sweating. So very important to make sure you keep up with fluid intake. And then also don't forget, if there's any relation of these symptoms, so whether it's sweating, just feeling chills, sweats, or just that change in temperature regulation, if there's any relation of that to, your dopamine regimen, more symptomatic when you're wearing off from your medications, then again, that might be time to talk to your neurologist. And maybe the strategy here is to adjust the medications you're taking for, helping you move better, the Parkinsonian symptoms. So this obviously would be a slightly different strategy than these lifestyle modifications I mentioned earlier. Very common to see abnormal nasal drainage in LBD as well. If anything, I think this is a underreported, under-recognized symptom because patients might often go to their primary care doctor first or, not even think that there could be a relation of this to LBD. So the fancy word for runny nose, you see it on the internet or from your doctor, we call it rhinorrhea. So very common in LBD. Of course, you do want to rule out, common things being common, that this is not a sinus problem, an infection in the respiratory tract that would indicate, needing antibiotics, for example, that this is not just uncontrolled allergies. But barring that, the other thing to consider, again, sometimes the medication that we're prescribing may also have, a little bit of side effect that can make your runny nose worse. So again, thinking about the memory thinking pills that us neurologists may be prescribing, so the Donepezil or the rivastigmine. So just keep in mind, did that make your runny nose worse? Now, granted, I've not had a patient where I actually had to discontinue, their memory thinking pill because of, rhinorrhea, by virtue, because I hope that they let me know so that I can help guide them. But if symptoms are, really quite bothersome, a very effective and easy management for, I would say effective for most, is trying nasal sprays and just over-the-counter Flonase. This can be very effective. And I would say this is much safer way to manage that than trying to take over-the-counter oral medications, or sometimes people do try to use allergy medications or Benadryl, for example. Again, we worry about those medications because of potential risk for worsening memory, thinking, cognition. So just beware, but nasal sprays like Flonase can be very helpful for the symptom. Not to forget about eye care in LBD, again, a very common issue. So dysfunction, whether it's in the tear secreting glands or, just on the surface of the eye. And then we take this along with the decreased blinking that we commonly see with LBD. These can all be ways why patients with LBD are prone to developing dry eyes. So symptoms can, manifest different ways, blurry vision. Sometimes you might tear up more, which is actually a compensatory mechanism, or you might have some of these other symptoms as well. So in terms of management, again, first thing first, take a look at your medication list. Are you on anything that could be drying you out further as a side effect? So again, water pill comes up as a potential culprit medication, and then antihistamines, so some of those allergy medications that you're trying to, for example, battle the runny nose, but it might also cause dry eyes, dry mouth. So just bear that in mind and see if, do you actually still need those medications? I always have a low threshold to refer to neuro-ophthalmology because, again, I definitely am by no means an eye doctor expert. So I want to make sure that they, assess our patients and make sure there isn't something else going on. Plus, they are really good at evaluating if this is due to dry eyes. They have very good strategies to share with you. But other things, again, make sure you're hydrated, consider adding a humidifier. And again, I usually defer ophthalmology to talk to you more about this, but sometimes certain eye drops or just over-the-counter artificial tears can help. And then things like, making sure you keep up with eyelid hygiene or, with therapy where you can do warm compresses and things to make sure eyelids are clean throughout the day may be another strategy. And then last but not least, this will be one of the final common autonomic symptoms I'll cover today in LBD is sexual dysfunction. Again, I think this is just not well studied. I think sometimes patients are embarrassed to talk about it, but this is very common, well recognized. And while we don't have a quick fix medication or sort of an easy strategy to manage this, again, if you don't discuss this with your doctor, we don't know how to, or we don't even know that it's a bothersome symptom for you. So very important to kind of discuss with your doctors more, especially if it affects your quality of life. And as you can see in this diagram over here, just to kind of highlight that many different neurotransmitter systems can be involved, and even things like cortisol, stress level. So it's a pretty complicated pathway or sort of intersection of different things going on that can contribute to sexual dysfunction. So this is better studied in men, but I listed sort of common symptoms that we can see in men and women. Again, take a look at your medications to make sure, is the sexual dysfunction a potential side effect from anything you're taking? A common example includes something like certain antidepressants. So again, it may be to review, can you benefit from switching to a different medication to help with mood without causing intolerable side effects? And then if you are prescribed, let's say, as needed medications to help with your sexual dysfunction, like Viagra, Cialis, etc., then just be careful if you are someone who's prone to low blood pressures, because these medications, as we talked about earlier, can make your orthostatic hypotension worse. So just be careful. And just keep in mind, as I kind of alluded to here, the complicated figure with sexual dysfunction, oftentimes, there can be a lot of different factors intersecting and playing a role. So, if depression itself is not well, managed, that can, potentially contribute to, your decreased libido. What about, are we potentially underdosing you in terms of managing your, Parkinsonian related symptoms or your movement symptoms? Are you having too much slowness, stiffness that's affecting your sexual performance, for example? Or is there uncontrolled pain that we need to better address? So treatment, not surprisingly, also comes down to likely a multidisciplinary approach to try to help you. So that segues to my second to last slide to really emphasize, as you can see, that managing LBD really takes a village. And, I spent the last hour just talking about one component of LBD with autonomic dysfunction. I didn't even delve into all the other things that, that this disorder may be, causing issues for you in terms of, movement, memory thinking, psychosis, sleep problems. So as you can imagine, all this just means is that it's a very complicated disorder, and we need really a whole host of different specialists to help take care of you. So I thought this was a really nice figure from this paper to kind of capture this idea. So at the very, very center, you have, person with LBD and their family, and usually you have a general practitioner and hopefully a specialized neurologist with LBD expertise, kind of helping you and your family on this journey. And then most have additional, help from therapists, so PT, OT, speech, maybe also dietitians, social workers, psychiatrists, neuropsychologists. And then additionally, you have, patients, depending on which symptoms are more problematic, you likely have additional, specialists on your team as well. And as I mentioned with the different autonomic symptoms, you might have cardiology, GI, pain specialists, etc., kind of part of your team. So it really takes a village, to help care for you and your loved ones. So with that, this is my last slide in terms of, take-home messages that I hope you can take with you when thinking about autonomic symptoms in LBD. We talked about a variety of different autonomic symptoms, but these are some of the common themes that I felt that I wanted to highlight. So don't forget, kind of go back and just take a look at your medication list and see, are you on anything that could be worsening your symptoms? It will be helpful to review this with your neurologist, with your primary care, and other specialists that are prescribing, other symptomatic medications. And then I always, for each of the symptoms we talked about in terms of autonomic dysfunction, I always try non-prescription sort of lifestyle, diet, exercise, type of management strategies first. And then don't forget, before you make any change, talk to your other doctors. So primary care being a common one, sort of almost like they are best aware of your other medical issues, but obviously you might have cardiologists, a kidney doctor, and other folks on your team. So make sure they are aware and on board with the changes that you might consider, whether it be lifestyle or even starting or stopping a medication, or if they have potential recommendations to kind of compromise, for example, some of those salt fluid diet changes that we talked about. And then finally, know that you are not alone in this journey, and always just keep in mind that, it's very important to tell your neurologist and your LBD docs, what are the symptoms that bother you on a day-to-day basis, because that's how we can best help you. And at the end of the day, that is our absolute ultimate goal, is in terms of trying to improve your day-to-day, your quality of life. So just know that you're not battling this by yourself. So with that, I just want to thank you so much for your attention. LBDA has done an amazing job sharing resources before, during the webinar, and they will also be sending out additional resources after this webinar. And in addition, feel free to check out some of these other organizations I included here, as they also have some useful information that may supplement or again reinforce things that we covered today. And with that, I just want to thank you so very much again for your attention.